So let's summarize all this different medication that we can use to treat patients with type 2 diabetes, and also briefly discuss the recent ADA guidelines that came out in 2024, because now we have all these drugs available, so which one are we going to choose for a specific patient? So I've written down now all the drugs that we went through. There's obviously also insulin. We're going to put it up top because when we are going to organize now the drugs based on the efficacy, I mean, for insulin, there's basically no limit, so you can reach any A1C lowering capacity with insulin. So I've put them here into the buckets being highly efficacious. These are those drugs, so high efficacy, which are going to lower your A1C more than 1.5%, around 1.5, and the dual agonists even more than that. Then we have our TCDs, which are in the moderate category, so lowering the A1C around 1 to 1.5%. And then we have our low efficacious drug, lowering the A1C below 1%. So now, based on the recently updated guidelines, the first questions you need to ask in order to choose which drug is appropriate for my patient is, does the patient have any heart or kidney disease or even any risk factors? So that's now the first question. And so if the answer is yes, well, if it is atherosclerotic cardiovascular disease or chronic kidney disease or just risk factors, we need to use GLP-1 agonists or SGLT inhibitors. We mentioned how much cardiovascular benefit they have and how protective they are to the kidney, so that's a way to go. If the patient has heart failure, the best drugs are the SGLT. So then we're going to take SGLT inhibitors. So the next question is going to be, how much A1C lowering do you need? So glycemic control. Obviously, always with the goal of avoiding hypoglycemia. So if you need to lower the A1C more than 1.5%, you may need two plus medications. If you need to lower it more than 2%, we are going to do dual therapy with injectable. And our injectables are the dual agonists and the GLP-1 agonists. And this is preferred over insulin. So insulin is basically always the last resort. And then if you have an A1C that's really high, like 12, 13, so then we need dual therapy with insulin, because the insulin is kind of open-ended. Now the last question we need to ask is, does a patient need weight loss? Because we have drugs that help us lose weight, and the GLP-1 agonists and the dual agonists are great in doing that, and they are even better than the SGLT, but they do so as well. So this is generally preferred over the SGLT inhibitors because they're just better at it. So again, to summarize the recent ADA guidelines, you just need to ask the question, does your patient have heart or kidney disease? If yes, you need to go to one of these drugs. If no, you can go to any of the others. Then we need to ask how much efficacy is needed, how much is the A1C above target. There may be more than 2 meds needed as we go up with the A1C. And then the third question is going to be, does my patient need a weight loss drug. And in this specific case, we're going to go either to the dual GLP-1 agonists or also to the SGLT inhibitors, just those are the preferred agent. This summarizes the video series on all kinds of different drugs to treat type 2 diabetes.